Hello and welcome. It is my pleasure to introduce you to the first USTMA Consortium educational webinar on thrombotic microangiopathies. This series of webinars will cover different topics regarding the diagnosis and treatment of thrombotic microangiopathies, or TMAs. The first session today deals with evaluation of the patient presenting with a possible TMA. TMAs are complex disorders with varied presentation, and I hope that our discussion today will emphasize how a multidisciplinary team is truly necessary to ensure the best outcomes. Now, the thrombotic microangiopathies are a diverse group of disorders, but they often share clinical manifestations such as low platelets, microangiopathic hemolytic anemia characterized by schistocytes from the blood smear, and varying degrees of microvascular ischemic organ failure. Although they may look similar clinically, the pathogenic mechanisms and then the treatments are quite heterogeneous, and multidisciplinary collaboration is critical to make the appropriate diagnosis and treatment. My name is Shruti Chaturvedi, and I will be serving as the moderator for this series. Our experts today are Dr. Rahil Kohli, a hospitalist at the Penn State University, Dr. Spiro Catalan, a professor of medicine and a hematologist at The Ohio State University, and Dr. Anuja Java, an associate professor of medicine at Washington University, where she is a nephrologist. We'd like to anchor our presentations on a case. Now, this is a 48-year-old woman with mixed connective tissue disorder, rheumatoid arthritis, obesity, and multifocal stroke that occurred about 1 month ago. She now presents with gait imbalance and thought she was having another stroke. On medication history, you find that she is on aspirin and clopidogrel since her last stroke and has also been started on a statin and lisinopril. Significant findings on physical exam are that although she is alert and oriented, she does have left cerebellar signs with dysdiadochokinesia and is unable to do the finger-nose test or tandem walk. A CT of the head in the emergency room shows that she's had either an acute or a subacute cerebellar stroke. An initial blood count in the emergency room also shows a platelet count that is down to 21,000 and a hemoglobin level of 10.1 grams per deciliter. Given that it appears that she's having a new stroke in the setting of severe thrombocytopenia, she is transferred to a tertiary care center for further management. And my colleague, Dr. Rahil Kohli, will take over from this standpoint.
Hi, everyone. My name is Rahil Kohli, and I'm currently a hospitalist at Penn State University School of Medicine, Milton S. Hershey Medical Center. And today I will be discussing the role of a hospitalist in the approach diagnosis of TMA. So I've included 4 key points in my presentation regarding the role of hospitalist medicine. This would include the initial evaluation, which includes the confirmation for the presence of thrombocytopenia and MAHA, exclusion of any systemic disorders that may contribute to these symptoms, confirming the diagnosis of primary TMA, the treatment process itself, and then, of course, the eventual recovery and discharge of the patient. So the workflow, it's a brief slide for the workflow of our service. So this would just include the sign out from the emergency room, the admission process itself, which would include the main bulk of our diagnosis process, and then the following up of labs, consult recommendation. So traditionally the ED would page our division for an admission, which would include a brief description consistent with something along the case for our patient would be a 48-year-old female, has a complex medical history, presenting with gait disturbances and concerns for a new stroke. CT head at an outside hospital was remarkable for the stroke, and the labs are showing thrombocytopenia, anemia, as we can see here, with some hemolytic labs that are also positive, and a serum creatinine of 2.6. And the patient is being requested to be admitted to internal medicine with a potential neurology consult in the ED itself. So when you receive a patient with these symptoms, time is always of the essence whenever you are considering primary TMAs versus other causes of hemolysis and microangiopathic hemolytic anemia, of course. So the initial evaluation for our service and myself, of course, will be a time timely manner to see the patient themselves, review the outside hospital paperwork, any prior imaging, coming up with a broad differential for someone who's presenting with these symptoms. And our bulk of the diagnosis would occur with the HPI and the physical exam itself. Then working collaboratively with our consult services, coming up with an assessment and plan that would cover all the differential diagnoses that we're considering, and of course, getting the patient to the right unit in a timely manner as well. So this slide is one of our more important slides, I would say. We already know that the patient has a history of connective tissue disorder and RA. We would always ask about patients' specific symptoms, such as other rheumatological diseases, such as lupus, any recent malignancies or a history of malignancies, and if they've been treated with any chemotherapeutic regimen previously, or any recent exposure to radiation, any uncontrolled hypertension at home, presence of CKD. Sometimes patients would know their baseline creatinine level. And in this case, we do know that the patient is coming in with elevated creatinine level of 2.6. Any presence of mechanical valves from before, recent infections or exposure to people with any sick contacts, any previous or recent organ transplants, and any recent strokes as well. Medications, we know that the patient's only taking 4 medications, but always important to include supplements as well, as they might not be listed on the patient's prescription fills. And of course, asking the patient if they're taking their medications or not. Other things, the social history, we somewhat do this intuitively, just asking about smoking, drinking, any illicit drug use, including opioids, any family history of similar presentations, rheumatological disorders, early malignancies or deaths, and of course, a thorough sexual history with a recent, if there's any recent pregnancies or previous complications with pregnancies consistent with HELLP syndrome. The vital signs would also be one of the more important things to rule out differentials, such as uncontrolled hypertension or hypotension consistent with shock. So if the patient has underlying uncontrolled hypertension, we would treat the underlying symptoms and then consider that as their main reason of MAHA. And then, of course, a head-to-toe approach when it comes considering any differential diagnoses. We already know that the patient is having some neurological symptoms. She is alert and oriented, but is having some cerebellar symptoms with discrepancy in her finger to nose, dysdiakinesia, and also tandem gait walk. And the signs of shock, so we would always consider infection as a potential cause for a presenting patient with thrombocytopenia anemia with the presence of hemolysis and not just other primary TMAs. Skin changes, any petechiae, any rashes that the patient may have noticed, and rheumatological exam, of course, as well. So the labs, we would confirm that the patient does have this anemia and thrombocytopenia, which we do know from the labs that were listed previously, establishing any kidney involvement, if the patient has any infectious concerns, including infectious workup. This would be lactate, blood cultures, your UA, and a chest x-ray just to start with, and then early initiation of antibiotics if there's concerns for shock. We have confirmed the presence of hemolysis previously, but of course this would include labs such as total bilirubin, reticulocyte count, and LDH, and haptoglobulin, and the peripheral smear, which is the key test here to confirm MAHA with the presence of schistocytes. And coags were already done. A Coombs test just to rule out any immune-mediated hemolysis, and an Adams 13 activity, which does have a lag time for, depending on the availability of our labs. This would be a turnaround time and the levels themselves. Moving on to management of our patient. So the main question for a patient presenting with a new stroke, hemolysis, and confirmation of MAHA um, from their peripheral smear would be to initiate therapeutic plasma exchange or to wait and fix any underlying issues that may be causing these symptoms. So that's the key question for this patient as well. So, and there's, of course, clinical tools that would guide us as to our confidence as to see if we need to be more aggressive or wait. And of course, our colleagues in hematology. So from what I would do in this patient is, of course, get our hematology colleagues on board, calculate the plasmic score for our patient, which was 6, and then, of course, order all the labs, which were already ordered, and then we did a pretty thorough HPI and a physical exam as well in order to accurately calculate our plasmic score, and then initiate the patient on IV glucocorticoids and confirm with our pharmacy and hematology colleagues for availability of alternative medications and our patients' qualification for these medications as well, while we're planning for therapeutic plasma exchange, which I believe will be discussed following my part.
Hello, my name is Spiro Catlin. I'm a hematologist at the Wexner Medical Center at The Ohio State University in Columbus, Ohio. And I'm going to give this brief presentation, Acute TMA, the first 72 hours, a hematologist's perspective. I'd like to start with a brief case, acute thrombocytopenia case, a case of a 40-year-old female with a history of a mixed connective tissue disorder, rheumatoid arthritis, diagnosed with a multifocal stroke approximately 1 year ago, who now presents with gait imbalance and concerns she was having another stroke. She's taking aspirin, Plavix, atorvastatin, lisinopril. Physical exam showed her to have some left cerebellar signs. Dysdagnokinesia, abnormal finger nose test, and failing a tandem walk. The CT scan in the emergency room showed an acute or a subacute cerebellar stroke, and laboratory findings demonstrated hemoglobin of 9.7, white count of 4,400, platelet count that was low at 15,000, MCV that was normal, and importantly some signs of hemolysis, an undetectable haptoglobin, and an elevation of the LDH. That should prompt a physician to look at the peripheral blood smear, and what you can see in this peripheral blood smear from this patient is 2 arrows. This arrow on the top showing nothing, showing the absence of platelets, really confirming the thrombocytopenia that was found in the CBC. The other arrow showing a fragmented cell or a schistocyte, confirming that this may indeed be a thrombotic microangiopathy presentation, leading to her clinical picture. The term thrombotic microangiopathy is really truly a pathological term used to describe microvascular thrombosis on tissue sections, primarily kidneys, when we talk about thrombotic microangiopathies. But it's also used as a clinical term as thrombocytopenia, fragmented cells, and evidence of hemolysis without a clear explanation. The term thrombotic microangiopathy has to be emphasized is not a diagnosis, it's a finding, and it can be seen as a result of multiple etiologies. We'll talk more about TTP and HUS. But patients with DIC, drug-induced TMAs, metastatic cancer-induced TMAs, autoimmune disorders, pregnancy can lead to several forms of TMA, including HELLP syndrome, infections, and in particular malignant hypertension that we'll talk about more later in this presentation, both as an acute and chronic cause of thrombotic microangiopathies. With TTP, you need to consider both a congenital form of TTP and the acquired or immune-mediated form of TTP. In the congenital form, you're born without this ADAM-TS13 protease. In the immune form, you develop an autoantibody that results in the clearance or the blocking of function of this protease, leading to the TMA presentation. With HUS, you need to consider both the classic HUS, the bloody diarrhea, where the bloody diarrhea precedes the TMA by a week, with recovery of the bloody diarrhea and then the development of the acute thrombotic microangiopathy. This is a Shiga toxin typically mediated process. You also have to consider complement-mediated TMA, so dysregulation of the complement system, a triggering factor that activates the alternative pathway, leading to uncontrolled complement-mediated damage, what we used to refer to as atypical HUS, now more correctly called a complement-mediated TMA. The most important first step, though, for a physician is to understand the likelihood of this being TTP, or put another way, the likelihood of severely deficient ADAM-TS13 activity being present to know if you need to start emergent plasma exchange therapy. And here are data shown from multiple groups that show a very clear pattern in the patient with severely deficient ADAM. So these are all samples taken before plasma exchange. The patient with severely deficient ADAM-TS13 activity had lower platelet counts and lesser degrees of renal injury. In the patients who had non-deficient, or we say measurable ADAM-TS13 activity, they tend to have a higher and greater degrees of renal injury, something you're more likely to see in a complement-mediated TMA rather than immune-mediated TTP. This plasma score has become very helpful. It's developed by the Harvard TMA Research Collaborative Registry and really allows physicians to predict the likelihood of ADAM-TS13 deficiency, a severe deficiency being present, and the need to start plasma exchange therapy. But I think you can also see it's really based upon the same data I showed previously. A platelet count less than 30,000. Evidence for hemolysis, no active cancer which can cause a TMA, stem cell or organ transplant not present, and evidence of renal injury, so less than 2.0 milligrams per deciliter. So you can see very quickly with a platelet count less than 30,000 and the serum creatinine less than 2 in the previous data I showed, with evidence of hemolysis, no cancer or organ transplant or stem cell transplant to explain the presentation, you can very quickly get into the intermediate or high risk for severe ADAM-TS13 deficiency. And these are exactly the patients you need to start empiric exchange therapy until you get the ADAM-TS13 activity back from them. So there's some TMA differential diagnosis, clinical hints or pearls that I think I can give you, things that we think about in addition to the platelet count and the serum creatinine. It needs to be remembered that most of these primary TMAs that we'll talk about, the TTP and the HUS, are rare disorders, and far more common is infection, hypertension, cancer, or autoimmune disorders leading to the TMA presentation. So you need to consider those, and many times treatment of this disorder will lead to resolution of the TMA findings that you're seeing. Hypertension can very certainly cause a TMA picture. And you're more likely to see this in blacks versus other races, especially when renal failure is involved. You're also going to have to consider acute versus chronic presentation. Certainly acute malignant hypertension can lead to hemolysis and renal injury. But with control of the blood pressure and resolution of the TMA findings, kidney function, kidney injury may recover. This would be more indicative of an acute renal injury and acute TMA. In contrast, a patient who may or may not show up with malignant hypertension at the time, but has a history of hypertension, may have chronic renal injury. So controlling the blood pressure may improve the platelet count and may improve the LDH. It's not likely to help the kidney dysfunction, given the chronic injury is present. I've already mentioned a little bit about the more classic picture and presentation is the bloody diarrhea that develops, that resolves after treatment, and a week later patients will show up with an acute thrombotic microangiopathy presentation and renal failure long after the bloody diarrhea is no longer present. Metastatic cancer can also give a similar clinical presentation from microvascular invasion of cancer. The postpartum state is also something that patients with TTP, both immune-mediated or congenital, are more likely to present in the second or third trimester, if not earlier for TTP. Whereas patients with a complement-mediated TMA are more likely to present with their TMA postpartum after their delivery. Some things to think about when you're assessing a patient acutely. It's very important to talk about a kidney biopsy and think about a kidney biopsy, but you have to understand the information that you're going to be giving. What you're really looking for on this kidney biopsy is not the etiology of the TMA, but rather the presence of the TMA. And you can see on the right here in some illustrative images from pathological specimens some of the findings you might see in acute TMA, including luminal occlusion, endothelial swelling, fragmented red cells in the vascular wall at times. Also, you might see fibrin deposition in the vascular wall with even luminal occlusion. So again, these are more acute findings that might tell you this TMA that you're seeing is more acute rather than chronic and scarring in nature. I like to think about primary TMA versus secondary TMA. And it's these primary TMA syndromes that are going to have a specific therapy for them. We've already talked a little about TTP, both immune-mediated and congenital TTP, where we're talking about plasma exchange or plasma infusion, respectively. HUS is primarily supportive care. A drug-induced TMA is really holding the offending medication, looking for recovery, and hereditary orders of vitamin B12 metabolism that need to be addressed more specifically and won't typically respond to complement-mediated complement blockade therapy. But you also have to consider some secondary TMA syndromes. So these are disorders that lead to the findings of a TMA, but there's a different treatment aimed at a different disorder. We've already talked about HELP syndrome, severe hypertension, so controlling the blood pressure, leading to improvement, eventually we hope, of the TMA findings. With malignancies and connective tissue disorder, treating them will result in the improvement of the TMA findings typically. We're not going to talk too much about complication of transplants, but both stem cell organs and solid organ transplants can lead to the development of an acute TMA. It's important to remember, again, as I've already stated, you need to understand that TMA is not a diagnosis, but it's a finding leads you to think about these potential etiologies. And some other things to remember. Not all microangiopathic hemolytic anemia is caused by a TMA. Mechanical hemolysis around a heart valve, something like that can also lead to microangiopathic findings that is not necessarily from a TMA. It's also important to remember that not all TMA findings will pre microangiopathic hemolytic anemia. You can rarely have patients with organ involvement of the kidneys, but not showing any peripheral blood manifestations of hemolysis and fragmented cells. And again, as I've already stated, the kidney biopsy is helpful to distinguish other causes of kidney injury from a thrombotic microangiopathy, but it will not tell you necessarily the specific etiology of a primary TMA. It cannot differentiate primary from secondary causes. Again, it's showing you the injury, and you need to use your clinical skills and testing to understand and differentiate the etiology of the specific TMA that led to those findings. The difficult question for clinicians is confirmation of TMA or atypical HUS. It's certainly a significant issue. And in the past, there's been this idea that a TMA with normal adequacy activity equals atypical HUS or a complement-mediated TMA. And that's certainly not the case. You need to consider other etiologies, as we've talked about already. Hypertensive history is an important clue. With a long-standing history of hypertension, you're going to consider that as an etiology of the TMA. But it's also important to remember that patients with a complement-mediated TMA will have a significant hypertension history associated with the diagnosis. You can think about a family history of a complement-mediated TMA, but remembering there's only a 30% penetrance roughly, so the genetic variant could be carried and not expressed in a patient. Eventually, you'll get genetic studies back, and 2/3 of patients will carry a genetic variant of the complement system, confirming the diagnosis. But in 1/3 of patients, you won't have that confirmation. Response to eculizumab is an important thing to consider. What you tend to see in a responding patient is shortly after starting complement blockade therapy, an improvement in the hemolysis parameters, the platelet count, and the LDH, with kidney injury or other end organs taking longer to recover. When you don't see that initial improvement in hemolysis followed by slow end organ injury recovery, you start to potentially question the diagnosis or think about other etiologies other than a complement mediated. The time to clinical response is again important, as we'll talk about in the next slide. The hematologic will get better in the first several days, typically, with end organ injury taking much longer. It's important to remember that the complement blockade therapy does not fix pre-existing injury, but just blocks further injury. If we look at data prior to the advent of complement blockade therapy, you can see half of patients with atypical HS, with the exception of patients with an MCP mutation, have a very unique and specialized course. Other than that, half of patients were dead or on hemodialysis within 1 year, roughly. So very significant. But again, complement blockade therapy in response to therapy, what you should see is the hematologic response first, followed by the recovery of the end organ injury, typically renal injury. And the quote I have from my patient always is, "I think the dialysis nurses don't like me." And this reflects the fact that she was starting to recover kidney function. She was starting to make urine on dialysis, and she thought she was bothering them by asking to use the restroom. And what this really is really evidence for the longer term recovery of kidney function that you can see. These are data from the very first licensing studies for eculizumab. And it's important to show very early on in the first couple of weeks of therapy, you see resolution of the thrombocytopenia, followed by on a more delayed basis, improvement in the glomerular filtration rate. But even after the initial study period of 24 to 26 weeks, you see continued improvement during this extension period. So this is really reflecting continued blockade of complement and allowing more time for recovery of kidney function. So in summary, it's important to identify the presence of the microangiopathic hemochromia and the possibility of a TMA diagnosis to explain those findings. Rapid identification of the likelihood of immune-mediated TTP is important in really identifying the need for plasma exchange therapy. You need to also consider the evaluation for both primary and secondary etiologies for the TMA, and the need to rapidly start complement blockade therapy when you suspect a complement. Thank you very much for your attention.
Hi everyone, I'm Anuja Java. I'm a nephrologist at Washington University School of Medicine in St. Louis, and it is a pleasure to be a part of this webinar organized by the USTMA Consortium, which is titled An Approach to TMA Diagnosis. And I have been asked to provide a nephrologist's perspective on the case that has been given to us. These are my disclosures. And before I begin with my initial thoughts, a quick recap of the case. What has been provided to us is a 48-year-old female who has a history of mixed connective tissue disease, rheumatoid arthritis, and is presenting with gait abnormalities. Her physical exam and CT scan are concerning for a cerebellar stroke, and we've been given a list of 4 or 5 medications. She has low hemoglobin and a low platelet count, and then is transferred to a tertiary care center for further evaluation and treatment. We are then also given a set of her labs, which again show low hemoglobin, low platelets, an elevated LDH, and a creatinine of 2.6 milligrams per deciliter, which is why I've been consulted to see this patient. So my initial thoughts are going back to her history. The patient has a history of an autoimmune disease, mixed connective tissue disorder, which is an overlap syndrome of lupus, scleroderma, and polymyositis. So I will be thinking whether this kidney disease could be related to her autoimmune disease. Could she be having a flare and causing an AKI because of that? But what is really glaring to us in this case is the constellation of lab abnormalities, which are anemia, thrombocytopenia, elevated LDH, and low haptoglobin. And all of these together are characteristic of a thrombotic microangiopathy. And the third thing that catches my eye in this patient is her medication list. As nephrologists, we are always looking at medications because, as you know, that lots of different medications can cause AKI in many different through multiple different mechanisms. So lisinopril, of course, in the presence of an AKI, we hold it off so as to prevent the aggravation of the acute injury. And so I would want to know how long ago this was started. Is this a new medication for the patient? And could that be aggravating her disease, and what we need to do about the medication? So, of course, the main concern here is a creatinine. One of the main concerns, I should say, is a creatinine of 2.6. And for the purposes of this talk, we're assuming that this is an acute kidney injury. However, without knowing what her baseline creatinine is, and by that I mean what it was a few days ago, months ago, weeks ago, it's without knowing that it's not entirely definitive reasonably possible to say whether this is AKI or whether there is a subacute or chronic component underlying, and what is the rapidity of progression. Regardless, like I said, we will assume that this is an AKI in this patient for the purposes of the two most important things that a nephrologist wants to look at is urine output. Is the patient peeing? How much urine he or she is making per hour or in 24 hours? And are there any electrolyte abnormalities, particularly hyperkalemia, metabolic acidosis, which are important for us to know to figure out if the patient is rapidly worsening and is there impending need for dialysis or renal replacement therapy, and whether we need to at least take care of that. And if that is not the case, then we have a little bit of wiggle room to start thinking about or teasing out the etiology of AKI in this patient. So as I mentioned, what is given to us is an autoimmune disease history, a TMA that she's presenting with, and then plus minus concern for some medications. So, as clinicians, our first thinking is to come up with a diagnosis that can, explain everything that may be going on in this patient. So coming up with a unifying diagnosis that can kind of tie in everything. And so in this case, when I think about her mixed connective tissue disease, we know that a severe complication of that is scleroderma renal crisis. These patients present with severe hypertension and a thrombotic microangiopathy, which is very characteristic of scleroderma renal crisis. It is thought to be secondary to this underlying autoimmune disease. These patients often have rapidly progressive kidney failure. They're oliguric, they present with hematuria, pulmonary edema, and if you did a biopsy in these patients, it would show fibrinoid necrosis. So, however, there are certain established risk factors for SRC. These include diffuse skin involvement of all the multiple different autoantibodies that these patients harbor because of their underlying autoimmune disease. Anti-RNA polymerase 3 antibody is most classically associated with scleroderma renal crisis. If these patients have been recently exposed to high-dose steroids, they are at high risk of presenting with crisis. And interestingly, relevant to our patients who've had prior ACE inhibitor use are associated or at risk of developing SRC. And the speculation there is that ACE inhibitor may mask hypertension and therefore may delay the diagnosis, and therefore these patients then present when they are actually in crisis. Regardless, like I said, given that this is an AKI, we would probably hold the medication. And in the snapshot that is provided to us, none of these risk factors have been mentioned now, whether she doesn't have them or they haven't been given to us right now. We don't know much about that. The second differential in my mind is that maybe her autoimmune disease is sitting in the background. It is not flaring up. And what she is presenting with is really a primary TMA process. And when you think about a primary TMA, there are two major subtypes of it, TTP, which is an ADAMTS13 deficiency-mediated process, or atypical hemolytic uremic syndrome, which is a complement-mediated process. So, you would send out for an ADAMTS13 level, you would look for C3 and C4 levels, which are simple and easy to send out, easy to be done in any local lab. What is really, really important to remember there is that if your C3 is low, then it is extremely helpful in these patients because that tells you that there is an active complement activation ongoing. However, if the C3 and C4 levels are normal, or if they're high, it does not rule out a complement-mediated process because they're also acute phase proteins. Another really simple, easy test that you can do in these patients is called the plasmic score, which helps risk stratify these patients to kind of get a quick assessment of their risk of having TTP. So the plasmic score consists of these different parameters that I mentioned on this table, and 1 point is assigned for each of these. So for example, if there is a platelet count of less than 30, the patient is given a point of 1. If there is hemolysis evident, 1 point is assigned to it. If there is no history of active cancer or no history of solid organ or stem cell transplant, each of them get 1 point. Similarly, MCV less than 90 is awarded 1, INR less than 1.5 is given a point, and creatinine of less than 2 is given a point. And the way this is scored is that patients who score anywhere from 0 to 4 are considered low risk for TTP, versus patients who have scored between 6 to 7 are considered high risk for TTP. So if we put the patient's lab findings and compare it to figure out what her plasmic score is, her platelet count gets to a 0.01. There is evidence of hemolysis given the elevated LDH and the low haptoglobin, that she gets 1 point for that. There is no mention of cancer or organ transplant in this patient, so 2 points right there. Her MCV is right below 90, so she's already at 5 points. Her INR is less than 1.5, that gives her 6 points. But her creatinine is not less than 2. So this patient scores 6 out of 7 on her plasmic score, and that puts her at a high risk of having TTP or ADAMTS13 deficiency. Of course, this is a quick way of assessing, like I said, while the ADAMTS13 level is cooking. Now, one may ask, we are trying to figure out, we know the patient has TMA. We're figuring out if this primary TMA or is it secondary TMA. And as a nephrologist, is there any role for a kidney biopsy in this patient? Can we do a biopsy and figure out what might be going on? Well, unfortunately, in most cases, just like this one, we are often limited in doing a biopsy because of thrombocytopenia and the risk of bleeding that will be associated with it. Even if not, a biopsy does not distinguish a primary TMA syndrome like atypical HUS from a TMA that may be occurring in the setting of another disorder like scleroderma in this case. However, a biopsy may be useful if one is trying to distinguish TMA from other causes of AKI. Could there be an ATN in the setting of autoimmune hemolytic cytopenias? Could there be ATN in the setting of malignancy or DIC? But overall, biopsy does not help determine the etiology and does not help determine primary from. So for this particular patient, given that her platelet count is so low and we have a clear-cut diagnosis of TMA, there is no real role of doing a biopsy in this patient at this point. However, I do want to mention certain aspects of the kidney biopsy that are important if a biopsy is done in a patient. There are certain terms or characteristic features that are important for anybody to understand. And so if there is mention of fibrin thrombi, that is a classic manifestation of TMA in the biopsy. Mesangiolisis, endothelial cell swelling, mention of a bloodless glomeruli are all features of thrombotic microangiopathy on a kidney biopsy. Intimal proliferation of frank necrosis. There are severe cases that may even present with cortical necrosis, and oftentimes the connection between cortical necrosis and a TMA is not made, and these cases are missed. If the TMA is burnt out and becomes chronic, there are chronic changes that can be seen on a biopsy, and these could present with duplication of glomerular basement membranes that could present like an MPGN pattern. The patients can develop interstitial fibrosis, and even an FSGS-like picture in some cases. Now, so at this point, just to quickly recap what we've discussed so far, we have a patient, we know she has a TMA, she has an underlying diagnosis of an autoimmune disease, and we are trying to figure out if this is a secondary TMA versus a primary TMA. So far, given that her plasmic score is high and she doesn't really have risk factors for scleroderma renal crisis, it seems like there is probably a primary TMA process going on. I expect that at this point in the patient's case, there is a rheumatologist who's being consulted for her autoimmune disease. There's a hematologist who's looking at the patient and working her up for TTP. But from a nephrologist standpoint, we still haven't looked at that second important component of a primary TMA, which is the atypical HUS or complement-mediated TMA. So if she truly has a primary TMA, like I mentioned, while TTP is being worked up, it is also equally important to make sure that this patient does not have a complement-mediated process that might be going on. And to kind of walk you through how you would do testing for complement-mediated defects in patients with primary TMA, I have designed this flowchart, and I'll just walk you through this. So once you recognize TMA in a patient, based on the features. If you look at the right square or the box that is orange colored, it kind of gives all the classic features of TMA. And in this patient, like as we've seen, that there is no question there is a thrombotic microangiopathy going on. So once you've recognized that there's TMA in the patient, you have the ADAMTS13 activity cooking, you have the autoimmune disease that the patient has, and if we think there is a flare-up, you treat that. If there is any other etiology, infections, anything else that may be the cause, drugs, medications, that may be the cause of TMA, you remove those precipitating factors. If the TMA persists in these patients, then it's very, very important that complement studies are sent out. And complement studies include two major aspects. One is genetic testing for looking for complement defects or complement mutations. And the other set of studies includes doing serum levels or serum testing for certain levels of complement components. And that serum testing includes C3 and C4, like I mentioned, looking for antigenic levels of complement regulators, factor H, factor I, MCP, which is membrane cofactor protein, looking for autoantibodies to complement proteins that may be the cause of the complement defect, the most common being factor H autoantibody, functional assays, which include CH50 and in some cases AH50. And in very, very select cases, you could actually look for certain split products that help define if there is ongoing complement activation in the system. And all of these testing, the plasma serum testing that is mentioned on the left, is available in select labs in the country. And as I mentioned, the other important component of doing complement testing is genetic testing, looking for complement variants. And this kind of testing should be done in a CLIA certified lab. Again, there are about 3 or 4 labs that do this testing. They run a panel of 13 complement genes, 13 common complement genes that are most commonly associated with atypical HUS. When the report is provided to you by these labs, if you have a pathogenic mutation in any of the complement proteins, it clinches the diagnosis for atypical HUS, versus if you find a variant of uncertain significance, which happens more often than we'd like it to, then you could contact specialized labs that can make these mutations in the lab or could do serum-based assays to test these mutations. And combining this testing, the genetic, antigenic testing, kind of helps define clearly if there is a complement-mediated etiology for these patients, helps define the prognosis, the risk of relapse, the risk of recurrence. And so it's important for me to emphasize here that all of this complement testing is critical, not to make a diagnosis of TMA, but to really define the course of disease for the patient downstream. Like I said, this is important to define whether there is an underlying complement etiology, how you would treat that patient, for how long that patient is going to need treatment, and what is the risk of, like I said, relapse or recurrence. So from a nephrologist perspective, like I said, I am thinking about primary and secondary TMA. I would be interested in under primary TMA while the TTP is being worked up. This is the testing that I as a nephrologist would be interested in sending out for this patient to also make sure that there is not, that aHUS is not the cause of a primary. So with that, I'll stop here, and I'll be looking forward to your questions, however the consortium has planned for that. Thank you.
And let's get back to our case. Just to review and repeat, our presenting patient was a 48-year-old female. She had a history of mixed connective tissue disorder, rheumatoid arthritis, obesity, and a recent stroke, and she's presenting with symptoms of a new stroke. Her labs were consistent with thrombocytopenia, presence of MAHA, renal impairment. We're unsure about the progression of this creatinine level and her baseline from the case itself, but that would be something that we would establish with the patient, and our repeat labs and trending. We calculated the plasmic score, which was 6. The levels were sent off for Adams T13, and the kidney biopsy was just deferred due to the patient's low platelet levels. And moving on to the management of the decisions that we've made for our patients. So this would be, we've done our initial workup, hematology, nephrology, transfusion team has been consulted. Decision has been made to initiate TPE for this patient. So the main thing would be to establish the appropriate central line and large bore IVs for this patient, initiation of IV glucocorticoids, and then confirmation of any complement mediated hemolysis, and then alternative medications as directed by our consult teams. And then, of course, we've contacted the blood bank to ensure that there's enough plasma and other blood products that are available. And now we move on to the monitoring phase of the patient, and then ensuring that our treatment is actually working while consistently revisiting our differential diagnoses from before if there's no response to our treatment. And of course, also monitoring for complications for any procedures with insertion of a central line, the TPE itself, any transfusion reactions, and then line-associated infections and other complications as well. So with the monitoring, we would constantly assess for the patient's response to TPE and any other medications that we've initiated. This would be in their symptoms, the platelet levels, and monitoring them pretty frequently with neurological exams and, of course, labs that are directed by our consult services and ourselves. Of course, monitoring for complications like we previously discussed, efficiently communicating with all our consult services for this patient would be hematology, nephrology, and neurology, while updating the patient's family and then monitoring the response if the patient has gotten better with our initiation of TPE. So a brief discussion about the steps that would follow once the patient does improve is just to ensure the patient has a good long-term recovery with rehab versus going home, ensuring close follow-up visits and communication with outpatient providers, and the discharge process itself that's taken care of by the hospitalist medicine. And a brief summary would be, through our whole presentation, what we've gone through and how hospitalist medicine can play a very key role in a patient who's presenting with these symptoms, as we may be the first people that are contacted for an admission. From the ED, the admission process itself with high clinical suspicion for TMA, and ensuring that the patient receives timely treatment and diagnoses with the lab results, and contacting consults as well. Confirming of MAHA and thrombocytopenia are the key initial tests, with the peripheral smear, calculating the plasmic score, actually initiating the treatment in coordination with the consult teams and your own clinical suspicion, initiating other medications, IV glucocorticoids, and of course the brief thing that we discussed about the discharge planning and the continuity of care, and updating families and the patient throughout their stay as well.
Thank you so much for attending the first webinar on TMA diagnosis. Next month, we will discuss management of complement-mediated TMA or atypical hemolytic uremic syndrome, and hope that you will join us. Additional information and resources are available on ustma.org. Thank you and have a wonderful day.